Uh, hello everyone. Welcome to our citywide psychiatry grand rounds. My name is Raj Rasasingam. I'm the CPPD director for the Department of Psychiatry, and thank you for making the time today to join us today. Before I begin, I would like to start with a land acknowledgement. I would like to begin with an acknowledgement of the land in which we work, study, and live. Before I read it, I want you to take a moment to situate yourself and think about the land under and around you. We recognize that many indigenous nations have long-standing relationships with the territories upon which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional territory of many indigenous nations, including the Mississaugas of the Credit and the Anishinaabe and the Chippewa and the Haudenosaunee and the Wendat people. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we're grateful to have the opportunity to live and work and gather on these territories. We acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit and the Williams Treaty signed by the multiple Mississaugas and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are a few places on earth that someone before us has not called home. So thank you. I'm going to go over a couple of housekeeping items, and then we will begin our grand rounds. An evaluation link will be sent to the attendees after today's presentation, and we really appreciate your feedback, so please fill that out for us kindly. Our appreciation today is extended to Dr. Maurice Freedman for doing this presentation, and to Baycrest Health Sciences. The next citywide grand rounds is on September 30th. It's a Garfunkel lecture. Lisa Dixon from Columbia will be presenting. I will now introduce Dr. Rob Madden, the Chief of Psychiatry at Baycrest, to welcome our speaker today. One last thing, please put your questions in the Q&A section. Thank you.
Thank you, Raj. So it's my pleasure to introduce my colleague and friend, Maurice Freedman. Dr. Freedman is the head of neurology and medical director of cognition and behavior at Baycrest. He's a professor in the Division of Neurology and in the Department of Medicine at the University of Toronto, and a scientist at the Rotman Research Institute of Baycrest Center. Dr. Freedman is carrying out research aimed at understanding mechanisms underlying cognitive impairment due to degenerative dementias. His research also includes the development of cognitive assessment procedures in dementia, such as the Toronto Cognitive Assessment and the Object Alternation Test, as well as program development for care of individuals with dementia. In addition, he has a special expertise in distance learning at a global level using video conferencing, an area which he has taken a major leadership role in internationally. Thank you.
Okay, thank you very much, Rob. What I'm going to do is share my screen first. So just bear with me for a moment. Getting organized here. Just want to get rid of the video panel. Okay. Great. Thank you very much. What I'm going to talk about this afternoon is an innovative model for care of neuropsychiatric symptoms and severe dementia that we developed at Baycrest. The program is called the Virtual Behavioural Medicine Program, VBM, and it's a real game changer in care for neuropsychiatric symptoms, and I'm going to explain what I mean by that. First, my disclosures. I am on the Research and Development Board of Cognicity. I'm a developer of the Toronto Cognitive Assessment, the TORCA, and I'm also going to very briefly discuss the use of medications off-label. Also, let me say that pretty well most, if not all, of what I'm going to be talking about today has just recently been published in April in the Journal of Alzheimer's Disease. And I want to list, this has really been a team effort, and I want to list my co-authors by name: Malcolm Binns, Fidelma Serediak, Uri Wolf, Einat Danieli, Brad Pugh, Deb Gallet, Eslam Abdella, Erica Teleg, Mindy Halper, Lauren Maskey, Adrian Lee, and Ann Kirsty. Okay, in terms of the objectives, what I'm going to do is I'm going to discuss the development of the initial concept for VBM, Virtual Behavioral Medicine Program. I'm then going to describe the model, and I'll talk about the clinical impact of VBM. So let me start where I'm going to end, which is with my key messages. And the key messages are that VBM, Virtual Behavioral Medicine Program, it focuses on the treatment of neuropsychiatric symptoms in dementia, especially agitation and aggression. It's a virtual inpatient neurobehavioral unit without walls or geographical borders. It's been highly successful in reducing the need for admission to specialized behavioral units, and I'm going to show you some striking data. And it's also a scalable model that can be adopted worldwide. In addition, although it's virtual, and a lot of virtual programs developed during COVID, the concept for VBM came before COVID. So just as a brief overview, I don't really have to go into detail for this audience, but let me just state that when I talk about neuropsychiatric signs and symptoms of dementia, I'm talking about behaviors such as agitation, aggression, delusions, hallucinations, hyperphagia, hypersexuality, hoarding, disinhibition, those sorts of behaviors. Let me just say one word about definition for one of these, and that's agitation, because this is a term that's really loosely used. And I'm using it to mean socially inappropriate verbal or motor activity, including pacing, aimless wandering, repetitious mannerisms, and restlessness. Now, there are two references at the bottom of this slide. There's one from 1989, Cohen Mansfield and colleagues. A more recent one was published by Uri Wolf, Yael Goldberg, myself in Continuum. This is a very good review of the assessment and management, both pharmacological and non-pharmacological, of patients with neuropsychiatric symptoms. Okay, I want to give you a clinical example before I go into the details of the talk, but common reasons for referral to the program are behaviors like hitting, kicking, pushing, throwing things, spitting, scratching, grabbing, cursing, screaming, disruptive noises. These are the kinds of behaviors that we see in VBM. So what I want to show you is a video before and after treatment. Now, this is an old video. It's not a patient in the VBM program, but it's the same kind of thing. And I'm going to show you a dramatic response. So this is a patient who was on our inpatient behavioral neurology unit, and you're going to see how he's quite aggressive. He's aggressive. I'm the person that he's being aggressive towards. So here's the video.
Can I see your hand? Can I see your hand? Can I see your hand? Lie down again. Can I just have your hand? Just hold my hand. No.
Okay, so this is a good example. What I'm going to show you now is a video post-treatment. And what you're going to see is I'm going to go up to this patient. and I'm going to offer him my hand, and he's going to take it without any kind of aggression. This is about after 2 to 3 weeks of treatment. And just in case anybody thinks that this is a fluke, I'm going to ask him to shake my hand again.
How are you doing? Let's shake hands. Yep. Shake my hand. Great. You've done very well. Yep. You've done very well. Yep. I'm very pleased. Shake my hand again. Yep. Great.
Okay, so that's an example of the kinds of responses to behavior that we are actually seeing and that we hope to see. This, by the way, is after about 2 to 3 weeks of carbamazepine. All right, let's go now into the details of the program. And let's look at the original rationale for this, how it all started. At Baycrest, we have an inpatient behavioral neurology unit, 20 beds. The focus is on treating agitation and aggression in dementia. And it's a very effective unit. The big problem is that there's a huge wait list, and patients can wait up to a year to get admitted. So we really needed a solution to this long wait list. So what we did is we started a pilot. The idea was, can we see these patients, the ones that are on the wait list? These are patients who cannot come to an outpatient clinic. They're just too aggressive, too difficult to get them to go to an office. But can we see them virtually? And can we manage these patients virtually? So the initial goal was to assess and to treat the patients on the wait list for the behavioral neurology unit. And as I said, it had to be virtual. And what we did in this pilot, when we set this up, we essentially set up a virtual inpatient unit. And the physicians in this program, myself and Uri Wolf, were exactly the same physicians that are on the inpatient unit. So there's no difference in physicians. And what we did is we developed a rating scale to document the severity of the neuropsychiatric symptoms. Now, it's important that I explain to you what this rating scale is, because I'm going to show you some data, and understanding the data requires understanding the rating scale. Let me just make one comment about terminology. I'm using the term neuropsychiatric symptoms. Some people use responsive behaviors. They're interchangeable for the purposes of this presentation, at least. So here's the scale. It's a 1 to 7 scale where ratings of 1 are the lower numbers are the more severe behaviors, and the higher numbers are better behaviors. So like a rating of 1, that's where the patient is so aggressive, they need admission to our inpatient unit. Nobody would dispute that. A rating of 2 is they clearly need admission, but it's not as bad as a 1. It's qualitative. And a rating of 3 means they need admission, but for non-physical aggressive responsive behaviors, like verbal aggression. So anybody with a rating of 1, 2, or 3, I think everybody would agree those patients need to come in. They're on the wait list, but some people on the wait list don't necessarily need admission. A rating of 4 is where they might be manageable. It's not clear whether they need admission or not. A rating of 5 is they probably don't need admission. A rating of 6 means that there's no responsive or neuropsychiatric symptoms there, but they're still in the program. And an example of why they'd be in the program, we may treat a patient very successfully. We may say, well, maybe we can hand over to the attending physician. You have to understand, we're seeing people in long-term care, acute care in the community. So maybe we can hand over the patient to the physician there. But the long-term care facility, for example, or the acute care facility will say, wait a minute, well, let's keep the person in the program. Let's wait another 2 or 3 weeks before we discharge. So that's a 6. And a 7 means they're successfully treated and they can be removed from the wait list. And an important point is that, where the patient's coming from. They're coming from long-term care, from acute care, and from the community. So we did the pilot, and it was amazingly successful. It quickly evolved into a full program. We actually eliminated our wait list within about 2 to 3 months. We obtained some funding for a secretary and a part-time pharmacist for our weekly virtual rounds, and I'll describe our virtual rounds a bit later. Also, let me say that the Virtual Behavioral Medicine Program, it's a partnership between our memory clinic, the Salmon Ida Ross Memory Clinic, and Behavioral Supports Ontario, BSO. BSO is involved in the intake process. They do focus on non-pharmacological behavioral approaches and outreach, and they make the connections between VBM and the teams in long-term care, acute care, and the community. And here is a map. This is 6 months old now. The reddish purplish colors are long-term care hospitals, and the bluish are acute care. And you can see that we're seeing people as far north as Huntsville. We see people in London and go east to St. Catharines and Simcoe, because there's just no borders to this. So, as I mentioned, we eliminated the wait list, this year-long wait list, within about 2 to 3 months. And the wait list for the VBM program is now about 2 weeks. So this is totally different from having patients come into the unit. Now, what we found was that this was so successful that patients were just referring sources were just referring people to the program and without an application to our inpatient unit. So what we did with this group, because some of them did require admission, even though there was no inpatient referral, we rated these patients, and we also looked at the reduction in the need for admission of this group of patients. So there's basically 2 sets of data. Patients who had an inpatient application, and they were seen in this virtual behavioral medicine program, and patients who were just referred to the program, but no application. And here is a striking graph. I want you to look at the left first, but let me explain to you what the axes are. On the y-axis, this is the cumulative percentage of patients that we saw. And on the x-axis on the left are the initial ratings, and on the right is the final ratings. Now, the colors, the 2 reds and this brownish, these are the ratings of 1, 2, and 3. These are the patients that are so severe that it's clear they need to come in. And this was 82% of the referrals. After treatment, you see what's happened? This has changed from a predominantly red and brown to large turquoise, which is discharged. And look at this ratings of 1, 2, and 3. It's gone down to 18%. Now that is a 78% reduction. Now, this is a dynamic process, and what we did is we sampled patients from the beginning, which was February 2020 to December 2020. We had 95 patients. So we basically sampled the group that we had. We sort of closed the sampling and we analyzed the data. So this is a 78% reduction with keeping patients where they are. You know, we didn't have to transfer people from long-term care to our unit or acute care or from the community. And just transferring patients makes the responsive behaviors, or can make the responsive behaviors worse. This is a very interesting graph. I'd never heard of this. It's called an alluvial graph. Never heard of this until Malcolm Binns, our statistician, showed it to me. What it is, it's the same as the previous graph. So here on the sides, you have the initial ratings and the final ratings. But what it shows is the connections, and it shows you how people are flowing. And you can see this is the rating of 1 on the left, the red, and you can see this big, huge group that went to turquoise, which is a rating of 7, which is discharged. The other thing is the ratings of 4, 5, and 6, which means they didn't for sure need admission. Nobody in that category went downwards in severity or increase in severity to a rating of 1, 2, and 3. So we managed to keep people who were not in the 1, 2, and 3 ratings out of that 1, 2, and 3 high severity rating. Now, this is what I mentioned before. We essentially eliminated our wait list in 2 to 3 months. Currently, our wait list is 0. Our wait list to get into this program is about 2 weeks. Now, mind you, we have set up a system to prioritize these patients, but we're able to respond very quickly, and you have to respond quickly to make this kind of unit successful. This is the data of the patients who were referred just to the program without an inpatient application. So here, I mean, it's a less severe group, and you can see that only 35%, 1, 2, and 3, we would have classified as needing admission. And after treatment at the end, it's only 15%. Now that's a 57% reduction of the ratings of 1, 2, and 3 in this overall milder group. Now this is a violin plot, and it gives you interesting information. What you have here is we have acute care, and in the middle we have long-term care, and on the right we have community, so that's the referral source. And on the y-axis we have initial ratings, and you see these little circles. Each circle is a patient, and the turquoise are people referred only to the VBM program, and this sort of reddish color are patients who also had an inpatient application. And what you see, as expected, and the high severity are lower down on the y-axis. So if you look at patients from acute care, you see that there are more circles lower down than in the other groups, and it was significant when you compare it to the community. Also, if you look at people who had a referral to the inpatient behavioral neurology unit, we look at the pairs, referral to the unit versus just VBM, you see that there are more circles lower down, which means more severe patients in those who have an inpatient application. And you see that if they're coming from acute care, you see that if they're coming from long-term care, and you sort of see that, you do see that from the community. So this slide, there's a lot of information, but I just want to make a couple of points on it. First of all, there are 95 patients, and this is acute care, long-term care, community, and it's about a third. So about 30%, about a third of our patients come from each of acute care, long-term care, and community. And when I talk about acute care, these patients are coming from both academic centers and from community hospitals. The other is, if you look at where they're being referred to, meaning do they have an application to the inpatient unit or just the VBM program, you see if they're in acute care and long-term care, about 3/4 have an application to the inpatient unit. But when they're in the community, it's about 50-50. Okay, so that's just information that describes the population. This slide is important for anybody who wants to develop a program like this, and we are encouraging that. This model is scalable. I would like to see VBMs all over the province, and we should see VBMs all over the world. What you see here is the age of the patients, okay? And what is striking is those who come from acute care are younger, and they're more often male, ratio of 28:7. Where if you look at the male-female ratio in long-term care in the community, it's about 50-50. So anybody who's going to try and set up a unit like this has to be prepared to accept aggressive patients who are younger and who are more likely male. And that often means that you have to have more security measures in place to protect the staff and to protect the other patients. This slide shows you the length of stay. Now, and it explains the length of stay. Just look at the graph on the left first, okay? The red are the patients who have been referred to the inpatient unit, as well as this VBM program. And the blue are the ones who are referred just to VBM. Now, if you look at those, and here on the y-axis is the proportion of patients in the program. And on the x-axis is the number of follow-up visits. So if you look at the red, those who are referred to who have an inpatient application, but they're all being seen in VBM, okay, they're all being seen virtually. By about 20 visits, there's only about 20% left who are in the program, which means 80% have been discharged. If you look at those who just had a VBM referral, by about 11 visits, about 80% have been discharged. Now, what's striking, if you look at the graph on the right, this is divided into initial severity rating, okay? And you see that the graph on the right and the left look very similar. So what it's telling you is it's not where they're being referred to that determines the length of stay. In other words, it's not that they've got an inpatient application or they don't. It's the severity that determines how long they stay in the program, and that's to be expected. This is the same data, but in duration of stay. So if you look at the 80%, those for 80% discharge, those who had an inpatient application, it's between 200 and 250 days, and those who were in VBM only, it's somewhere around 170, 175 days. And again, if you look at the duration by days, but break it into initial severity rating, you get the same kind of thing. So it doesn't matter how you look at it, by duration of days or number of visits, the determinant for how long they're in the program is the initial severity, not whether there's a coexistent application. This graph is interesting because it shows you the number of follow-up visits and the proportion in the program by here and the length of stay in days, but it breaks it down into where the patients came from. Acute care, long-term care, and community. And there's no difference. These graphs, you can see that the tremendous overlap. So how long they're going to be in the program, it doesn't matter where they're coming from. What matters is the severity. So I want to shift now to the concept of healthcare team. It's very important. In a standard model for a physical inpatient unit, you basically have a fixed team. You may have rotating attending physicians, but basically it's the same team. In the VBM model, it's totally different. You have a fluid team, and the fluid team varies with the location. And the team is comprised of the VBM team at Baycrest, plus the teams in long-term care, acute care, and the teams in the community. And the team changes based on which patient we're seeing and where they are. And there's a two-way capacity building when we do this. There is a capacity building in that the teams in long-term care and acute care, and we're seeing the same teams over and over again now. They are learning from us how to manage the behaviors, but we are learning from them because for example, I'm learning better how things work in long-term care and how to make things work in long-term care when dealing with these neuropsychiatric symptoms. The same thing goes for acute care. The community, it's also a learning experience because I'm working with various community services that I don't normally come in contact with without VBM. So it is a two-way capacity building system. And I think that's very good. But the concept of healthcare team is very different from a fixed unit. Now, I talked about our virtual ward rounds. This is a virtual unit. And what we do is we are set up every week. I do mine on a Tuesday. Dr. Wolf does his on I'm not sure what day he does it on. And on a Tuesday, we have a team. I have a pharmacist, we have a nurse, we have fellows. And I will literally go from one facility to another, spend maybe 10, 15 minutes at each facility, and we do rounds. And we make recommendations for treatments. When people are in long-term care, we fax the prescription for approval by the attending physician. In acute care, if the physician's there, they write the prescription. If they're not, we fax a prescription so they can look at it and approve it later. We also make ourselves available between visits by email, by telephone. So we're basically functioning as a real inpatient unit that's virtual. So we're available on the same kind of basis. And this is extremely important in order to make this work. We also have the idea of a virtual waiting room. What I mean by this is if we start running late, there are people waiting for us in long-term care and acute care. We call them. We have a secretary calls them and says, we're running late. And then they go and do other things. And we call them when we're ready to do the visit. And this is very important so that people aren't just sitting around waiting for us. And this applies to the community as well. And it's important for all virtual care, not just the VBM program. The worst thing is when somebody's sitting there for an hour. When they're in a real waiting room, they can actually see that there are other patients there and they see the secretaries and they know that everybody didn't go home. When somebody's waiting for a virtual visit and they can't see anything, they actually wonder whether somebody forgot them. And after about an hour, they begin to think that no one's going to come and see them. So this is important for all virtual care. So what are some critical service requirements for this? Good communication is essential. We're getting now to know our referring sources, but we need to be able to communicate, to understand each other. We need a short wait time. There has to be frequent follow-ups. We have to be available because sometimes things happen between visits, just like an inpatient unit. And there also has to be a prompt dictation and faxing of the letter. So our letters go out very quickly. Even though we're talking to people, there needs to be written documentation. And the physician isn't always there when I'm meeting. Sometimes it's the allied healthcare staff that I'm talking to. Sure, they talk to the physician, but I don't always have a conversation with the physician. Looking at how we can do things better in terms of preventable referrals, of our 95 cases, 10, which is almost 10%, were discharged after the initial assessment, which means they didn't need the program. 7 clearly didn't need it. And 3 were going to be followed by their psychiatrists. Now, many of our patients have psychiatrists and are referred by psychiatrists. But in these 3 cases, there was a communication breakdown in that the psychiatrist who was following the patient was planning to follow the patient and wasn't necessarily looking to the VBM program to get involved. So, knowing these kinds of things in advance, I think, well, that's important. And other patients could have moved into these slots. Let me make a comment about pharmacological versus non-pharmacological approaches. First of all, about 80% of cases can be managed without a referral to the VBM program. And this includes people who are managed by the Behavioral Supports Ontario or other groups using non-pharmacological approaches. About 20% can't be managed with non-pharmacological approaches alone. And it's that 20% that usually require medications. And it's that 20% that we're seeing in VBM. So yes, we use a lot of medications. Those who are doing the non-pharmacological approach are often on the visits with us. They want us to use medication. These are the patients where the non-pharmacological approach has not been sufficient in and of itself. But the non-pharmacological approach works together with the pharmacological approach in our patients. This is a slide. I mean, I have a whole separate lecture on how you actually manage these patients, but I just wanted to show you that there are lots of drugs. They fall in different classes, and basically one has to, I'm talking to a very sophisticated audience in using psychiatric medications. But let me just say that there are classes: antipsychotics, anticonvulsants, antidepressants, lorazepam, clonazepam. There are drugs, cholinesterase inhibitors. There's this miscellaneous group: prazosin, memantine, nabilone, CBD oil, and there are other medications as well. I mean, it's a given that to have a program like this, whoever's the physicians involved have to know what drugs are available, how they interact, what the side effects are, and how to use them. Anyway, that's a whole separate lecture. So I want to go back to the key messages. And I gave you these at the beginning. The key messages are that this VBM program focuses on the treatment of neuropsychiatric symptoms and dementia, especially agitation and aggression, but not exclusively. It's a virtual inpatient neurobehavioral unit. Let me make a comment. There are virtual hospitals, and virtual care has been around for a long time. What's novel about this is as far as I could ascertain, I've given these talks internationally, and no one's come up and said they've done this. No one has had a virtual hospital unit for neuropsychiatric symptoms in dementia. So that's what's novel here, that this is a virtual inpatient neurobehavioral unit for neuropsychiatric symptoms. It's been highly successful in reducing the need for admission to specialized behavioral units. So we're keeping people out of emergency departments, out of transfers to units such as our behavioral neurology unit. It's a scalable model that can be adopted worldwide. We would like to see it adopted worldwide, and I'd like to see it adopted province-wide. I mean, this is, I think, a really important model that can help keep people in their environment and can help manage patients with responsive behaviors. I want to make the point that it preceded COVID, and I want to give a special thank you to our excellent team. This is something that requires teamwork, and our team has really risen to the challenge, and I want to thank all of them. So on that note, I will stop, and I will be happy to answer questions. I'm going to stop sharing.
Dr. Freedman, Thank you for that wonderful presentation. I mean, it was very engaging, and I love the integration of data and practical examples. And you know, it's something that is very intriguing, not only to our audience as a geriatric psychiatrist, but to our general audience as well, because a lot of people practice in the ER setting. And one of the sort of high volumes, acute things that come in is you know, we have a lot of patients sometimes coming in from nursing homes to the ER because they can't, because of the traveling issue, because they can't go to a clinic, for example, right? I can really see this having significant value in maybe reducing ER visits as well. I mean, I know you are focusing on inpatients and your own program. Has there been any thoughts on that part? Is there a reduction in the number of ER visits in regard to this patient population?
Okay, we need to get data on this, okay? But,
yeah.
Okay, putting the fact that I don't have data aside, I can talk from experience, okay? So I've had referrals where it could be a psychiatrist, it could be a neurologist, a geriatrician. Anyway, I get a call saying, this patient is going to end up in an emergency department. We've heard about your program. Can you see this patient? So what we do is we see the patient. And we do prioritize, I mean, our wait list is like 2 weeks, but a patient like that, I have one in mind that I saw, and I saw the patient within a day or two. That patient not only did not go to the emergency department, they are pretty close to, we're talking about long-term care application. And I've got several cases like that, where they did not go to the emergency department because of this program. Now, one thing also, and I mentioned the being available. You see, once a family, let's say this patient was in the community, but once a family knows that they can reach out to you, you know, just call you, email you, their tolerance level, you know, increases because they know they're not alone. So they're less likely to call 911. They're likely to call us and they say, okay, we're making a change in medication. We're going to follow up in a week or 2 or 3 days. That is very important. And that also helps keep people out of emergency departments.
No, totally. I mean, it is an amazing tool in terms of caregiver burden, in terms of, healthcare facilities and how, the wait, as you said, the wait list is pretty much non-existent. Just to follow up on, you mentioned the emails, there was a question about how much time is spent in between virtual rounds on email and on the phone.
Very little. You see, that's a very interesting question, because my initial thought would be we'd be flooded with emails. But because people know that, first of all, just knowing they can contact us is reassuring. And and we see these patients almost weekly, most of them are seen weekly. So, if it's Thursday and they know they're going to see us on Tuesday, they wait. I mean, so I'm telling you that it's amazing how we get, I mean, I don't know, about 5, 6, 7 emails a week. It's not a lot.
Great. There's lots of feedback. This is a wonderful presentation, as I mentioned, the applicability in so many ways. There was a question about, I think you touched on it, but about some of the highlights of the treatment itself. Is there some kind of references you could provide? I mean, I don't know if that can be done afterwards as well, but any thoughts on that?
Yeah. First of all, that article, Wolf Goldberg and me, Continuum is the continuing education journal in neurology. It's through the American Academy of Neurology. That one really goes into detail about approaches and drugs. But the real answer to your question is hard to find in an article, because many of the patients that we see have already been on most medications. So then it becomes using medications that other people haven't thought of, perhaps using medications that aren't commonly used, combining medications in different ways. It becomes pretty complicated, because these patients have been treated already.
Yeah, absolutely.
But read that article. That article is what I would recommend.
Articles of research. Thanks. There was a question about how is this program funded?
Yep.
There?
Yeah. Well, it's basically funded through Baycrest. We had we got early on a grant for, I think it was $197,000, and that allowed us to get some secretarial support and some pharmacy support, but that grant is over. We need ongoing funding to sustain this.
Yeah, definitely. And I hope that, I mean, I can see the practical uses in so many ways, and I hope that they'll continue. There was a question about, I know this is slightly different from the scope of the presentation, but there's a question about behavioral approaches, some detail on some of the behavioral approaches that you've used on your patients.
Yeah. And let me just preface that by saying that these patients, the behavioral approaches themselves, they're just these patients are too severe for just that. Okay, so they do need drugs. But examples of behavioral approaches are trying to explain to patients, as best as possible what you're doing. If you're going to take them into some people are terrified of showers, make sure it's not that the water is too cold. Make sure they're not with, like, there's one patient who didn't want a female giving him the shower, so having a male give the shower. It's those kinds of things that, looking at how you're feeding someone, how you're doing the care, how you're approaching the patient. Those are examples of non-pharmacological intervention. Music is another approach, getting people involved and engaged in activities that they like. But these patients are beyond where just doing that solves the problem. They don't get to us if that solves the problem.
Yeah, absolutely. Yeah, as you were saying, 80% in that category, right? There was a question about the different subtypes of dementias. Is there one more, amenable, works better on one versus the other with respect to this virtual program?
I haven't actually looked at the success data. Like, for example, the patients that were discharged versus not by diagnosis. That's something we need to do. However, again, having said that, I'm not talking from data. My impression is that regardless of the type of dementia, we manage to be successful. Now, the approaches may be different. For example, if somebody has dementia with Lewy bodies, I mean, we know that those patients can have neuroleptic sensitivity. So I wouldn't, starting an antipsychotic would be the last thing I'd want to try. So, for example, if the patient was psychotic, I would try a cholinesterase inhibitor, which can have antipsychotic properties. Whereas if the patient was psychotic and had Alzheimer's disease, I'd be more likely to try an antipsychotic. So I think the approaches may be different. Frontotemporal dementia, they may have a serotonergic deficit, so I may lean towards one type of medication. My sense in terms of success rate, I have not been struck that there's one group, one diagnostic group that is harder than the other to treat.
Thank you for that. There's a question here about, they really like this program, and really offers options to people, stay in their own place, right? Do you see patients staying in their environments for long-term after discharge from the program? So, after discharge, do you see successes within their own settings?
Yes. Yes. Some families, let's talk about the community, okay? Families have two different goals depending on, some want to keep the patient at home. Some want the person to go to long-term care, but they're too aggressive to be accepted. So I have many patients where they're kept at, they stay at home after we treat the patient. I even have two patients that were in acute care hospitals in academic centers who ended up going home, and they're still at home, okay? But there are those where the goal is long-term care. The caregiver just can't manage, but the patient is not being accepted to long-term care. But yes, keeping people in, I mean, for a person, it's the best thing for a person is to be in their own familiar environment, and home is often better if the resources are there.
Yeah, definitely. They were asking, is there, consent, a question about consent. Do you delegate the consent for medications, or do you engage with the patient itself? How do you manage all this kind of dynamic?
With these patients are not capable, I shouldn't say always, there's always an exception, but these patients are not capable of consenting to treatment. So the consent falls to the substance decision maker, power of attorney for personal care. When they're in the community, that power of attorney is often the person who's with them. In acute care hospitals and long-term care, the consent to treatment has to be there. What actually happens in those settings is the actual order for the medication is written by the physician there. What we do, when I don't have the physician there, rather than waiting for the note to get, we actually fax the prescription. And then the nurse shows it to the attending when they come in, or he or she calls them, and the attending writes the order. But yes, we need consent.
Thank you. There's a question or follow-up about, what is the comfort level in long-term care settings of waiting for a virtual assessment rather than, directly sending them to emerge? There's a question about that. Your thoughts?
In long-term care settings that don't know about the program, where they just heard about it, but they're not really sure, there's often a great anxiety. They want the patient in our inpatient unit today. They want the patient transferred. Once I start working with them and explaining, their comfort level goes up. And when I see the patient for the second, when I see other patients from that same home, it's hi, how are you? To the staff, and the comfort level is actually great. Now, we do admit patients. I mean, there are patients who we can't manage. And you see the long-term care facilities know that if we're not successful, we will take the patient and transfer them to our unit. So that also increases the comfort level.
Yeah, that makes sense. There's a question about technology. If there's issues with technology in the community, what are the families not able to access the necessary technology or applications? Thoughts on that?
Yeah, I mean, it's common. First of all, problems with this technology are common. Everyone we've seen has at least been able to connect with Zoom. We prefer OTN, but that doesn't work for everybody. But there are times when the sound doesn't work, and we use the telephone for sound and the video for voice. But the technology is a challenge. But all of the patients that we see in this program, I mean, I have to see the patient. For something like this, to treat a patient like this on the telephone would be very difficult. That's almost a reason to admit. The visual is extremely important here.
Yeah, totally. There's a question here about what kind of training do caregivers receive around non-pharmacological approaches? How do they access the skills to carry these out?
Okay. All of the patients referred to our program go through Behavioral Supports Ontario. Behavioral Supports, we have an office here, and no referral comes to us without going through them. So there is, and the BSO interacts with the families in the community. in long-term care, there often is a behavioral support person, but that is not the family so much as the staff. So for the families, we have BSO.
Yeah, okay. Now, there's lots of questions about, you know, there's an example of a question of a patient with schizophrenia and dementia. Do they still have a right to refuse treatment? You know, there's a lot of burnout, you know, taking care of the patient at home. Any thoughts generally on these types of dilemmas?
Patients who have the capacity are certainly have the right to refuse treatment. The patients that I see in this program, with rare exception, do not have the capacity to make a decision about treatment.
Okay. You know, what, again, there was a question, a little bit more clarification on what exact disciplines does the VBN provide, and is there a difference in success, community versus long-term care?
You know, we've got to look at that breakdown in data. My sense is that it's no different. You know, I just look at the people that we discharge from different places, and I say 30% come from each, and we have a high discharge rate from community, from long-term care, and from acute care.
Mm-hmm. Okay. You know, you were talking earlier about the hope of expanding this to other networks, other areas. You know, give me your thoughts on the dissemination and where it's going for the future, the next couple of years.
Okay, let's talk about Ontario. Okay, no matter how many patients we see at Baycrest, it's still not going to be enough, and this problem is getting bigger and bigger. So to disseminate it is going to require, what has to happen is there has to be centers in the province that want to do this. So they're going to need to have a physician and they're going to need nursing support, administrative support. Be good to have a pharmacist. That's going to cost, that needs funding. So what I really think needs to happen is government, the provincial government needs to, you know, make this a priority and needs to fund the emergence of these VBMs across Ontario. Now, I'm certainly and would very much want and supporting these new groups. You know, helping people set this up. I mean, we've been doing this. We've learned a lot of things. We're still learning. Where we help other people set this up, have collaborations among programs, but it needs government support. And so the government's got to say, this is what they want. And I really think, you know, we've had our inpatient unit, you know, for many, many years. And it wasn't until 2019, early 2020, that I came up with this idea. Should have thought of this 20 years ago. I mean, VBM, you know, virtual care has been around for a long time.
Yeah, yeah.
Sitting there ready to go.
Yeah, absolutely. You know, lots of positive feedback as well. There was one question about, do the patients have to be, does it have to be, you know, dementia, Alzheimer's? Could there be other kinds of things like brain injury, neurodevelopmental issues with, could that type of patient be referred to your program?
Okay, we want, dementia is a criterion, but people with traumatic brain injury, with developmental disorders, we see those patients when there's dementia as part of it. So for example, I have patients with developmental disorders, but they've been progressing. So there's something occurring there. There's another disease that's occurring. It's often a neurodegenerative disease of some type. So we see those patients. So in other words, head injury and developmental disorder are not exclusions, But if it's just a head injury, that's a different type of patient. You know, a head injury with stable behaviors, and there are other programs for patients with those problems.
I'm going to answer one, try to follow one last question before we end. In terms of involvement of home care, LINs, et cetera, community dwelling patients, I mean, do you ever advocate for services, in these areas, specific types of supports that needs to be put, has to be put in place? Do you provide the linkage to supports, following the program?
Yes, we do. We do that through the BSO, the BSO, they're called BSOTs, BSO team members. We do that through the BSOTs. They connect with the families, they make connections with the community. So the answer to your question is absolutely yes.
Dr. Freedman, thank you for this wonderful presentation and talks. I know I can't answer every question, but they can always reach out to Paula Panic or myself, and we will connect them to you. But this is a wonderful program. The feedback has been exceptional. And thank you again for making the time to speak to the psychiatrist at large in the citywide psychiatric rounds. And we really appreciate it. And, and I really wish success for the expansion of this program as well. Dr. Madden, do you want to say any last words on your behalf?
I just want to thank everybody for attending, and congratulations to Dr. Freedman and the team for having very significant impact in the healthcare system. And I've heard this talk a number of times, Morris, and I'm impressed every single time I hear it. It's just amazing.
Yeah. Thank you again.
Thank you for the opportunity to present to your group.
You're most welcome, and thank you again. For our group, we'll be taking a break in September. We'll start back up with the citywide psychiatric grand rounds. So have a good summer, everyone, and thank you again for joining us today. Take care. Bye.